Bخش Hospital. We are very happy and proud to be with you. I'll be speaking in English in case if anyone is doesn't speak Arabic. And the lecture is going to be a very detailed lecture on pediatric knee MRI. I thought that this subject is a subject that needs a bit of attention. There's a lot of overlap in this topic between the adult knee and the pediatric knee MRI. But there are few differences that should be, that everyone who is dealing with patients in that age group should be aware of, so they don't fall into the pitfalls of misdiagnosing some of the injuries that we face. So the lecture basically is going to be mostly on sports injuries. Nothing that is actually goes into, I'm not going to go into oncology, or I'm not going to be talking about bone lesions in this lecture. So let me start saying that the knee joint is by far, as we all know, is the most commonly imaged joint by MRI in the pediatric population. And the usual indications are just to look for internal derangement, pain, and if there's a radiographic abnormality that is seen on the X-ray, that they want to confirm it with the MRI. So the overlap between the adult and the pediatric injury, there are specific abnormalities that are specific for the pediatric age group, and those are the ones that I want everyone here to take a message home from,
Recording in progress.
To take home from, and do not fall into the pitfalls that happen with that kind of injury. So when I was taught MRI of the knee, the first part is the anatomy. I was first told that if you would, a good analogy of the knee of any patient, it looks like a baby high chair, like the one that we see over here. So if we think about the knee being this joint over here, which looks like the baby high chair, so the cruciate ligaments are the straps that you put on the baby so the baby doesn't fall to the front or the back. And the collateral ligaments are actually the straps that you put on the sides so the baby does not fall on the sides of the chair. And the menisci are actually the padding that you put underneath the baby's so it doesn't. So the patient would have, or the baby would be comfortable sitting on that high chair. So this is the simplest anatomy analogy that I could think of. Now, if I bring an anatomy sketch just to show you what an MRI, what a normal anatomy would look like, we would see that this is the femur, and this is a flexed knee, as we can see. And we can see this is the lateral femoral condyle and the medial femoral condyle. This is the anterior cruciate ligament and the posterior cruciate ligament. And over here we're going to see the lateral meniscus and the medial meniscus. And over here we're going to see the patella, and we're going to see the patella cartilage. So this is just to give you an overview of anatomically how the knee looks like. Now, about protocol. This is the protocol that I used to use when I was in my fellowship, and things has not changed. So this is just a slide that is peculiar for any technologist who is attending with us. We usually use sagittal T1 for the anatomy, and sagittal Melk. Melk is a sequence that is usually used in Siemens machines, so it is equivalent to the PD FATSAT, and it's actually a gradient sequence. But for us radiologists, it gives us the same information. And transverse Melk, chronal T2 FATSAT, sagittal 3D flash FATSAT, and oblique sagittal T2 for the ADCL. And we keep the field of view to 15 centimeters. The field of view is important. Sometimes if we put a very large field of view, we can lose on the resolution of the images. So we have to keep in mind that we keep the field of view as appropriate to the patient size, so we can get the best image quality that we can get. Now let's start talking about the menisci. We start by the menisci because they are the ones that are most commonly deranged in skeletally immature knees. The incidence of meniscal tears in pediatric population is less than that of the adults. The meniscal injuries are more than the anterior cruciate ligament injuries in the pediatric population. Like in the adults, the medial meniscus is mostly injured more than the lateral meniscus. And the posterior horn is more affected than the anterior horn. The sensitivity of MRI in detecting meniscal injuries is as high as 85%, and the specificity is as high as 100%. Like the grading that we've heard of before, some people like to use the grading of meniscal injuries. I don't use it that much, but just in case, if I say to you if it's a grade 1, that means it's a normal meniscus. That's why I don't like to use it. It can confuse people. If I tell them grade 1, they might think there's a grade 1 injury, but actually grade 1 meniscal signal means that this meniscus is normal. And grade 2, and here what we face sometimes problems with especially in the insurance population that we have. So grade 2 is when you have high signal within the meniscus, but it does not reach any articular surface. And this is, we call it mixed-site degeneration in adults or persistent vasculature in pediatric population. And I do know that in some studies that actually 50% of those, they turn out to be tears. But by the book, at least the grade 2 is actually not a tear. But grade 3 is when you see an intrameniscal high signal that is reaching an articular surface, and now this is a tear. So what are the tears? This is an important slide. So there are 6 types of meniscal tears. We have the horizontal, which are the most, like the degenerative kind of tears are mostly horizontal, and vertical tears, which are the traumatic ones. The bucket handle tear, which we're going to see a good example of in a few seconds. Radial tear, peripheral tear, and displaced flap tears. Those are the most common tears. I'm going to talk about the bucket handle tear, which is a surgical one and an important one to talk about. And it is very important to understand the pathophysiology of bucket handle tear. So, if we have any junior staff amongst us. So a patient with a bucket handle tear typically presents with locking and requires surgical attention, and that's why this kind of tear is important. A bucket handle tear is a longitudinally oriented tear of the meniscus with a torn fragment flipped centrally into the intercondylar notch, and the imaging findings that is associated with it is actually the double PCL sign, the famous double PCL sign, and the displaced fragment of the meniscus in the coronal plane. So let's take an example here. What's the double PCL sign? Let's just focus over here on this image at the bottom left corner. So if we see that this is the medial meniscus over here that we see, and there's a tear, there's a longitudinal tear that happens with this red tear over here. And this will leave us with this fragment that looks like actually a bucket handle. So if we lift this bucket handle and put it into the intercondylar notch, now we will have the double PCL sign. That will look like this over here that we're going to see as we have. This is the posterior cruciate ligament. There's another fragment seen beneath it that looks like another PCL, but this is actually this flip fragment that actually went underneath the PCL over here, and that's why we call it the double PCL sign. It is an indicative of a what we call a bucket handle tear of the medial meniscus in this case. Now let's look at it on the coronal plane, and I'm going to show you a few sequences, or actually a number of images through the coronal sequence over here, so you can understand what we see. And I'm going to highlight the flip fragment by this orange color, so you can see. So this, now we are at the anterior aspect of the knee. This is the medial, this is the lateral, and this is the femur over here, and this is the tibia. So this is the fragment that is flipped, and we can see it again over here. And this is the fragment that is flipped, and this is the parent meniscus or parent medial meniscus. That is the part of it that stayed in place, and this is the flipped fragment over here. Again, you can see the flipped fragment in the intercondylar notch, and this is the part of the meniscus that has not flipped. And again, over here, now we can see that this flip fragment is actually going just underneath the posterior cruciate ligament. And now, again, the flip fragment underneath the posterior cruciate ligament, which will give us the double PCL sign on the sagittal view classically. And it goes all the way, and you can actually connect it to the posterior horn of the, or the posterior root of the medial meniscus. So if you go back and forth, you're going to see that fluid fragment is going anteriorly to posteriorly, like a fluid fragment in the intercondylar notch. So this is what we call a bucket handle tear. It is usually those patients present with locking, and usually they require surgical treatment for it to be reduced. Now, the absent bow tie sign is a sign that we usually use. I don't use it that much because it really depends on the thickness of the images. And it indicates if the patient has a what we call a discoid meniscus or not. So on sagittal imaging of the knee, from peripheral to central, the body of the meniscus should be seen on at least 2 to 3 consecutive images if the sequences were 4 to 5 millimeters thick. And they should have a bow tie appearance. Unfortunately, again, this sign is not reliable in the pediatric population because the variable size of the menisci depends on the patient's age. So over here, this is a normal MRI, a sagittal 3D sequence. We can see that there's the bow tie sign that we can see here. We see it on more than 2 images, which is normal. Now, the absent bow tie sign here, we do not see the meniscus. You know, this is the first image. Second image, we lose it. We only see the bow tie, which is this one, on one sequence, which is not enough. That means this patient must have at least a radial tear. Now, the discoid meniscus is a normal variant that we see, which is an inline meniscal body. So in the 10% of the pediatric population will have, it is present in 10%, but in our practice we see it less. It is almost, I've never seen a discoid medial meniscus before, but they're almost uniformly happening in the lateral meniscus. They're more common in females, and because you have a bigger meniscus, a bigger target, then it means that you get more tears in that big meniscus. So the children with current menisci most often present between the age of 10 and 15 years when the symptoms occur. So this is where you see the patient presenting with issues. So how can you diagnose it? If you see the meniscal body at least 3 or 4 images, or if you measure 2 millimeters difference in the thickness of the meniscus, or if the width of the meniscus is more than 12 millimeters. I'll show you an example. Now this is, again, a sagittal sequence of the knee. This is the femur over here, this is the tibia, this is the medial meniscus over here. This is the lateral meniscus that I did outline to you, and you can see that the meniscus doesn't look normal and it looks bigger than usual. If we measure the width of this meniscus, it will measure approximately 2.6 centimeters, which is far way more than 1.2 centimeters, which qualifies this meniscus to be a discoid meniscus if you want to go by a ruler. Again, I teach my residents all the time, a radiologist with a ruler is a radiologist in trouble. Don't just go by the numbers, you go by the clinical judgment as well. So again, if it is like here, it does definitely look more than lateral discoid meniscus, even morphologically, even by eyeballing. You don't need this, measurements. We use the measurements in equivocal cases. If we are not 100% sure, we go back to the numbers. Again, the thickness of this meniscus over here is approximately 6 millimeters, and the one on the left, the medial one is 3 millimeters, and the difference is 3 millimeters, which is more than 2, then we can call this a discoid meniscus. So this is an example of a discoid meniscus. There are associations. They present with a high fibular head, hypoplasia of the lateral femoral condyle and tibial spine. They can present with a joint space widening on the lateral aspect, or meniscal cysts. They can also present with that as well. Okay, now we're done with the menisci. We're done with the bucket handle tears. We're done with the discoid meniscus. Let's talk a little bit about the cruciate ligaments, and this is a very important part of this talk. Because ACL injuries are very frequent and we see them a lot in the pediatric population. They're most prevalent in girls, and for few reasons, that the girls have more joint laxity. It is contributed to maybe hormonal factors, to limb alignment issues, configuration of the intercon notch in the females looks a bit different. The ligament size in the females looks a bit different. And possibly because we know that the females actually mature or close their mature before their male counterparts, then they will have issues because they have earlier fusion of their physeal plates. The accuracy of MRI in detecting meniscal and ACL tears in adolescents is comparable with that of adults, but reportedly less accurate in patients before physeal closures. So there is a little bit of less ability to diagnose them, but it is very comparable between the pediatric and the adult population. So what are the signs? As we all know, the signs of ACL tears is the fiber discontinuity. You see that the fiber is cut. If the course of the ACL looks abnormal, if the signal of the ACL itself looks abnormal, I will think about the primary signs. But personally, I don't really only rely on just those 3 factors. I also rely on the secondary signs. If there is any increased angle and abnormal vertical orientation of the PCL, because we know if the ACL tears that the tibia will be translated anteriorly, and in this case the PCL, instead of having this like a ponytail appearance, it will start to have like more of a 7 because the tibia has pushed anteriorly a bit, so this will give us the 7 appearance. And that is because of the anterior tibial displacement. And if there's uncovering of the posterior horn of the lateral meniscus, also, I will look at the sagittal sequences, and I will see the position of the tibia and the position of the posterior horn of the lateral meniscus if it is uncovered or not. And lastly, the kissing contusions of the lateral femoral condyle and the medial tibial plateau, because we all understand that the ACL tear actually happens because of this pivot shift type injury, because the tibia is stuck to the floor and the femur is actually rotating internally, which puts stress on the ACL, and then the ACL snaps and tears, and then the femur goes back and the lateral femoral condyle hits the posterior aspect of the tibial plateau, and this is how you get an ACL tear. So again, the pattern of the bone marrow edema in children has been seen in cases that you see that kind of edema, but the ligament is not torn, so it is not so much reliable. Again, the sensitivity of 95% and the specificity of 88% has been detected in ACL tears in children by Lee et al. Using both primary and secondary signs. So again, ACL is not a black and white thing. I look at it as a whole, as a big entity, and I look at every single sign that I use to come up with a conclusion. It is not as if the fiber is discontinuous only or not. It is more than that, and that's why it is more of a clinical judgment as well to learn. Again, primary findings are, of course, the most reliable in diagnosing cases. So the ligaments as well, which meniscal avulsion of the and avulsion of the tibial spine. These are the secondary signs, which actually we see the bottom 3 of them more, and then we can recommend an MRI to see if the ligament is intact or not. So that's what I teach the residents all the time. If you see an avulsion of the tibial spine, if you see a Sigon fracture, if you see an impaction of the lateral femoral condyle, then you can recommend an MRI to see if this patient has a torn anterior cruciate ligament or not. So these are not sensitive, but they are just an indication for an ACL injury. Again, over here, this is an example of a patient that that's why in pediatric patients, when you get an X-ray of the knee with a history of twisting trauma, you really have to look closely because you can really miss those findings very easily. Over here, you can see that the tibial spine is avulsed, and there's a lucency at the bottom of this medial eminence, and there's also a Sigon fracture. Sigon fractures are tricky, they're not easy to see. If you do not look for them, you might easily miss them. So you have to have this subconscious, at least, feeling that I have to look for it. So again, this is the MRI of this patient, and you can see this T2 or hypointense line over here. This is the avulsion of the anterior cruciate ligament. And we know in pediatrics, the ligaments are actually stronger than the bones, so the avulsion of the bones is more common than the adult population. Again, but again, the end result for that is the same, because the patient will have a malfunctioning anterior cruciate ligament. And over here, you're going to start seeing that there's a Sigon fracture. The Sigon fracture, there has been multiple hypotheses. I have published with the orthopedic team in King Abdulaziz University on that issue. Initially, it was thought that the Sigon fracture is due to capillary avulsion of the that leads to this. Now there are talks about there's a new ligament that they actually trying to coin, which is the anterolateral ligament. It is actually thickening of the capsule. They are just trying to call it a ligament, and avulsion of the anterolateral ligament, or the ALL, is what contributes to this Sigon fracture. So this is an example of a patient who presented with trauma, twisted in soccer with effusion, ruled bony injury. Again, if you look closely, you might see nothing, but if you look again closely enough, you're going to see the Sigon fracture. So Sigon fracture is happening in this case, and on the cross-table lateral view, you're going to see that there is a fluid level, so there is a fracture over here. This patient needs an MRI definitely to see what is going on. And then when you do the MRI, and there is here the uncovering of the posterior horn of the lateral meniscus, the tibia here is hence translated in relation to the femur. And in addition to that, there's this very tiny bump here, or sorry, indentation over here. So if I look at this image only, I would start thinking that this patient must have an ACL without even looking at the ACL itself. And if I go more medially into the joint and I start looking for the ACL, oops, there's no ACL, the ACL is gone. This means that this patient has a full thickness there of the anterior cruciate ligament in this case. And this is the posterior cruciate ligament over here. And there might be also some truncation of the posterior horn of the medial meniscus in this case as well. So this was the ACL injury. I hope I have covered most of it for you, so you can have a feeling of how an ACL injury can look like and what is the appearance of the ACL injuries. Again, just to take home message from the ACL injuries, plain x-rays, please have a look at the Sigon fracture, have a look at the tibial spines very well, look if there is any joint effusion, and the dip in the lateral femoral condyle is very important as well. And then come up with a look at the MRI and look for the ACL, look for the anterior tibial translation, look if there's uncovering of the lateral posterior horn of the lateral meniscus and the bone marrow edema pattern, and then come up with a conclusion if there is an anterior cruciate ligament injury or not. Let's come to the posterior cruciate ligament. It is uncommon, but actually the classical way that there is an anterior force that happens to the knee in a flexed knee, or it can happen with extreme hyperextension. So with extreme hyperextension, possibly avulse the posterior tibial plateau without tearing the PCL, and that is usually, again, due to capsular detachment. Over here, again, it's a lateral radiograph of the pediatric knee, and if you don't look closely, you won't see it. But if you look closely over here, you're going to see that there is this lucency over here with the bony fragment seen posterior to it, that this is the posterior cruciate ligament attachment over here that has avulsed and took off some of the bone with it. So this is the posterior cruciate ligament detachment on the posterior tibial plateau. And this is the corresponding MRI to the same case. You're going to see a bony fragment over here. This is the PCL that doesn't look normal. It looks thickened and avulsed from the posterior aspect. This is a coronal MRI of the same patient. This is the lateral aspect of the knee. This is the medial aspect. This is the fibular head. And this is the posterior aspect of the tibial plateau. And this is the lateral femoral condyle posteriorly and the medial femoral condyle posteriorly. And you're going to see this hypointense line over here, which is actually the avulsed fragment of the posterior cruciate ligament. Now into the collateral ligaments. the collateral ligament injury is relatively uncommon, and it usually happens to the MCL, which is the medial collateral ligament, and it's secondary to valgus stress. If some player exerts some pressure on the lateral aspect of the knee of a player, then they're going to have this valgus stress on the knee in a flexed position, and you will get injury of the MCL. There is grading to the ligament injury. The grade 1, which we call the microscopic injury, but the ligament is intact and there's just surrounding edema around it. The grade 2 is the partial tear, where the ligament is thickened or has abnormal signal with surrounding edema. Complete tear, when you actually see it wavy and disrupted. So again, I'll repeat, microscopic injury is when you just see some amount of fluid superficial to the medial collateral ligament. Grade 2, when there is actually abnormal signal within the ligament itself, but it still, you can still see the ligament course normal. And grade 3, when you can see a complete tear. Okay. So over here, this is an example of grade 1. This is the medial aspect on a coronal PD fat sat sequence. This is the medial collateral ligament over here, and this is the fluid that you see superficial to it. And this is again an example of grade 2, but on the lateral collateral ligament. You're going to see some high signal over here, but you can still see the lateral collateral ligament. This is a grade 2 LCL injury. And lastly, but not least, is the wavy appearance of the medial collateral ligament, and this is the grade 3 injury that you can see over here. Now, bone and cartilage. So this bone and cartilage are very important in the pediatric group for so many reasons, and the growth plates are very important to look at as well. Any injury to the growth plate can lead to leg length discrepancy in the pediatric population, and this is an issue, so we have to be really careful in looking into those. So before the physeal fusion, the growth plates are a weak area and potential site of injury, and they're very important to look at. And the most common type of injury in those physeal plates is the Salter-Harris type 2, and is the most common fracture diagnosed on MRI. So Salter-Harris type 2 is the most common, as we see in this case over here. So this is the growth plate over here, and then we see this high signal in the growth plate that goes superiorly consistent with this Salter-Harris type 2. If we see that there's no this component, but the component goes all the way through, this will be a Salter-Harris type 1. If there is involvement of just the epiphysis, it will be Salter-Harris type 3. And if it goes through and through, is Salter-Harris type 5. Type 4, sorry, and type 5 is when you have this just crushed physis over here. But by far the most common one that we see on MRI will be the type 2, and it is important to report because you want to know if there's involvement of the growth plate and if this patient will suffer from some leg discrepancy or not. So it is an important part to be aware of. The other thing is the physeal widening because of the stress injury has been reported in these small little athletes. And because there's a chronic type of injury, the fracture line is not seen, but you just see widening that can be focal or throughout the physeal plate. If you have heard before the term gymnast wrist, this happens more in the rest of those patients in the distal radial growth plate. The patient comes and reports pain. They're usually gymnasts that exert so much pressure on their wrists. It can happen anywhere, including the knee. So if you have a normal X-ray, an MRI can be abnormal, and the physeal plate can look abnormal, and this is what you call the stress injury to the physeal plate, and it is something to be considered. As you can see over here, this is a focal widening or abnormal hazy appearance of the medial aspect of the growth plate in this patient, because you can see that the lateral aspect of the growth plate looks pristine. So now you have an explanation of this patient, why is he presenting with pain, why he's not performing well in the matches or in his training. So, and this will have an implication on those athletes, and we have in our community here in Jeddah a large group of players that are actually trying to play professionally, and you're going to see more and more about these kind of injuries, and we will have to deal with them. So the growth plate injuries can be, so this patient has to get rest, and we will be treated in a way to prevent some injuries to the fascial plate. Again, before fascial closures, the avulsion of the tibial spines are not rare, so you can see them a lot. In most cases, the ACL is intact, but the tibial spine avulsions may occur in association with ACL tears. As I told you, before the fascial closures, the bones are actually weaker than the ligaments, so the ligament will detach the bones, and it can happen more with patients with wider intercondylar notches because they are predisposed to tibial avulsion fractures. This is another patient that presented to us, caught his right leg in the bike frame while biking and twisted his knee, and now he's presenting with swelling and decreased range of motion. And if you look very closely over here, I think you're going to see that there is something going on in the tibial spines, and you have to have a very good look at, and then you're going to see there's some lucency over here, and this is again a tibial spine avulsion fracture. In addition to that, if you look very closely over here, there's a sigmoid fracture as well. So the tibial spine avulsion fractures, they're not easy to pick up. So whenever you report plain films, have very good and close look at those tibial spines, just to make sure that this patient has, doesn't have a tibial spine avulsion injury. Now, osteochondritis dissecans is a bit difficult to understand, especially if you're a junior resident and have not been exposed to this kind of entity before. It is an acquired condition in which an osteochondrial fragment is partially or completely dislodged from the articular surface. Yeah, just to keep it in simple words. So it is an acquired condition. The patient is not born with it. And what happens actually, the bone and the cartilage in that part partially is displaced in this area. And sometimes they think it is post-traumatic, but the theories include this is repetitive mechanical stress, congenital factors, maybe avascular necrosis. Some people even predispose that they are caused by fat emboli. Nobody knows exactly why osteochondritis dissecans happen. In the knee, by far, is the medial femoral condyle lateral aspect. I use mnemonics a lot in my teaching, so I use the word lane, L-A-N-E, so the lateral aspect of the medial epicondyle is the most common place for the osteochondritis dissecans, or the OCD. And 85% of cases are in the lateral aspect of the medial femoral condyle. Inferior central lateral femoral condyle can also have it. The anterior aspect of the lateral femoral condyle can also have it. And the femoral sulcus and the patella, very, very rare. I haven't seen cases like that. Most of them actually happen in that specific site. We can see it by X-ray as a focal lucency of the subcorneal bone containing the central osseous fragment. But MRI is definitely the study of choice, because we want to see if there is instability or not, because it will determine if this patient will be treated conservatively or will go to surgery. So the signs, what are the signs of instability? These are very important to keep in mind. If you see a high signal on the fluid-sensitive sequences, a long fragment interface, so between the bone fragment and the parent bone, there is what we call a fluid signal intensity. If there is disruption of the subcorneal bone plate, that's another one. And if there is a 5 millimeter or larger fluid fields adjacent to the region. Funny enough that these signs of instability are actually the same signs of instability we use for the OCD instability in the ankle, for the tailor dome OCDs. So the same thing applies here, so you can remember it both for the knee and the ankle as well. So over here you can see a central lucency, a lucency that we have seen in the classical place for the osteochondritis dissecans. You can see a lucency over here and a bone fragment seen within. This is osteochondritis dissecans. Again, another one over here, you're going to see this is an osteochondral lesion, and even the cartilage underneath does not look normal, consistent with osteochondritis dissecans. And again, over here, you're going to see you can go all the way. So this is an unstable osteochondral lesion that we can see over here. Somebody is chatting with us. Okay, so We will have questions and answers after the lecture. But there's an important point to keep in mind to differentiate the OCD from the normal variant. There's a variant of ossification usually at the posterior aspect of the lateral femoral condyle. The trick of here is to know the location and to assess the cartilage on top of it. The location of the normal variant is usually the posterior aspect of the lateral femoral condyle, but the cartilage overlying it will be normal. So over here, you're going to see that this is lateral femoral condyle. You're going to think that there might be an osteofemoral lesion, but this is how the normal variant looks like, so don't fall into the trap of that. Again, this is the MRI of a normal variant. This is not an osteochondral lesion. This is the posterior aspect of the lateral femoral condyle, and this is just the ossification center has not completely fused at the lateral aspect of the lateral femoral condyle. The cartilage overlying it is completely normal, so keep that in mind. Same thing and same idea. Now, let's go to the patellar tendon and the patella. They are very important in the pediatric population because of the displacement of the patella. So complete or usually lateral, by far the most common displacement of the patella out of the femoral groove, which is usually spontaneous, and the patient happens spontaneously and comes back. Sometimes it's not recognized. But then indirect signs, the patient might present with hemarthrosis, contusion, or osteochondral injury of the medial patellar facet and the lateral femoral condyle, and the injury to the medial patellar retinaculum, and you have to have a look at it. But it is this subject is actually deeper than that, because you have to assess the external mechanism and see if this patient has a high riding or a low riding patella, which we call a patella alta or patella baja. And to see, and also to assess the trochlear groove in this patient to see if there is patellar maltracking, to see if this patient is at risk of recurrent dislocations of the patella or not. So these are all very important issues. The patients that usually present with patellar dislocation, they usually have genovalgum. They will have knock knees with ligamentous laxity and shallow femoral groove, femoral trochlea, an abnormal morphology of the patellar facets. As we see in this patient over here, the trochlear groove is very shallow, which actually predisposes this patient to patellar dislocation, and we can see that the medial patellar femoral ligament is abnormal here with maybe an avulsion of the medial patellar aspect over here. So the same patient, you can see the classic bone marrow contusion pattern involving the lateral femoral condyle and the medial aspect of the patella. So this, if I see this, it's a transient lateral patellar dislocation. Most likely there's a shallow trochlear groove, the medial patellar femoral ligament is disrupted, and this patient usually will be treated by our colleagues in orthopedics. Now let's go to the patellar sleeve fracture. It is an important thing to differentiate the patellar sleeve fracture from the usual sending Larsen Johansson, which is another entity that affects that inferior wall of the patella. It's usually an acute avulsion of the cartilage of the inferior patellar cord with a benign bone fragment. It usually happens in patients between 8 to 12 years old. And the patient will have some radiographic and MRI findings like fusion, avulsed osseous fragments, and the patella alta or high-riding of the patella. MRI can show the full extent of the lesion. As you can see over here, this patient has a very subtle patellar sleeve avulsion on an osseous fragment over here that avulsed. The patella is somewhat high-riding, consistent with the patella alta. How to determine if this is high-riding or low-riding patella? We use the inside-salpati ratio, which is basically when you measure the patella length over the tendon length, it should be 1 at least, just roughly. In this case, the patellar tendon is up shorter than the patellar tendon, or the patellar length is a lot shorter than the patellar tendon length, and that means that this patient is having a patella alta with this avulsion that we see over here. Usually in sending Johansson, you only see thickening, but you don't see the involvement of the posterior aspect. Usually the sending Larsen Johansson, which is the chronic repetitive avulsion of the patellar tendon over here, you don't see it very well, and this patient is having actually a patellar sleeve avulsion injury. So again, this is the MRI of the same patient. You can see the involvement was mostly posterior in this patient with this sleeve fragment that is went off the patellar inferior pole of the ear. So this is the patellar sleeve of all the This is my neck. I kept it to 45 minutes, so I can give you 15 minutes for Q&A. If anybody has any questions, please fire them, and I'm more than happy to answer.
Thank you, Professor, for this informative lecture. We are honored to have you in Boston.
Okay. Any questions?
Yeah, there's out. Oh, I'd like to thank D.خالد. It's very informative. A bit laborious for me. It's very technical for me. صراحة أنا very hard to understand اللي قاله D.خالد. So I'd like to thank you so much. يمكن الدكتور راني يساعدنا. And my question is about how many cases of such cases mentioned by D.خالد we see in بخش. Are they common ولا لا؟ عندنا في بخش في الكوميونتي حقنا أو من الأورثوبيديك ستاف ممكن يساعدنا. ما أعرف الدكتور راني إذا كان موجود. How they involve, I mean, from a radiological point of view and from a surgical point of view لو عندنا من الأورثوبيديك.
يعطيك العافية وشكرا. Thank you Dr. خالد والله. يعني very nice lecture, and you cover the whole most common thing in pediatric. Actually, we have actually a good amount of cases pediatric who present with trauma, but unfortunately not much of them go to the MRI. However, I saw, and you see most of these cases, especially patellar instability injuries, we saw lots of fear in Bach Hospital. Few cases of, I've grown to have a fear. Also, we have some cases of that in Bach Hospital. It's good to have this attention about the these avulsion fractures that we found later. So actually, this kind of lecture we need to make awareness of our ER and orthopedics about the knee of the pediatric that is really prone to have all kinds of these injuries that Dr. Khalid clearly demonstrate. Especially the tricks that he showed us in the X-rays that many times it can be missed, especially the people, the person who is not quite familiar to read the X-ray of the pediatric or immature scalpels. So I think this lecture will increase the awareness of all these injuries.